infections among adolescent girls and young women and lead to transformational improvements for women and girls. This is a 45-minute session. We will have a panel, we have an excellent panel lined up, followed hopefully by a session of question and answer from the floor. Please use your Q&A button to send your questions, which we will be tracking. Without further ado, I would like to introduce my first speaker, who is Professor Francisca Mutapi. She is a board member for Uniting to Combat NTDs. Professor Francisca Mutapi will start us off by setting the scene around the current state of affairs for FGS, which is female genital schistosomiasis. She will also be joining the panel discussion afterwards. Professor Francisca is a global health researcher and leader who has over 25 years of experience conducting basic scientific and implementation research on schistosomiasis. So we wouldn't have been even luckier to have someone who has really been working in this field. Prof, please take the floor. Thank you.
Great. Thank you very much for the invitation to contribute, and good morning to all the listeners. So, schistosomiasis, commonly known as bilharzia or snail fever, is the second most important parasitic disease in Africa. It is caused by waterborne parasites, and people become infected when they come into contact with infected water. There are three things you need to take away from my introduction this morning. First, the burden of schistosomiasis is huge. It affects over 228 million people worldwide. That's just a little under the current global burden of COVID-19, which is at 266 million at the moment. Second, one form of the disease, which occurs amongst women and young girls, results from the damage of the urogenital tract by the parasite's eggs. It is called female genital schistosomiasis, as you heard, or FGS for short. And it includes the swelling of the vulva and the vagina, bleeding and pain. FGS can then progress to reproductive organ damage, infertility, ectopic pregnancy, spontaneous abortion, premature birth, and low birth weight. The third and probably most important thing you need to take away is that this disease is completely unnecessary because it is treatable and preventable. So it is time we put an end to FGS. We've known about this disease for over 100 years, first described in Egypt in 1899, and then further characterized in Zimbabwe, then Rhodesia in the 1950s. So the question you must be asking me now is why on earth I am talking about FGS at an AIDS and STI conference? The answer is very simple. There's growing evidence that FGS predisposes women to sexually transmitted diseases, including HIV. The first body of this work demonstrating the association was actually conducted by my colleagues in Zimbabwe in the 1990s. Since the launch of the WHO and UNAIDS joint advocacy brief, No More Neglect, Female Genital Schistosomiasis and HIV at ICASA 2019 in Kigali, there has been growing evidence on the urgency to address FGS in order to reduce susceptibility to HIV and other STIs. You will hear from my colleagues here this morning about the mounting evidence of the link between FGS and HIV and how this can be reversed by early treatment of schistosomiasis. It is critical to prioritize the treatment of FGS as a means to control HIV infection. Currently, women of reproductive age and girls outside school fall into a treatment gap for schistosomiasis. This is because schistosomiasis control programs are targeted primarily at school children. This misses the majority of the girls out of school and, of course, women of childbearing age. You will hear from my colleagues later in this panel discussion that treating schistosomiasis is effective at reducing FGS, especially in the early ages, and that treating FGS as part of the sexual and reproductive health package ensures that we capture these women that are missed in these current treatment programs. Treating FGS makes sense, not just at an individual level, but also as at a population level, because it avoids the cost of treating the downstream effects that can be a burden on the health system. In the case of the health systems, this is a global health security issue. Weakened health systems anywhere in the world compromise the global health security. We know this already from the Global Health Security Agenda. So as long as schistosomiasis is a huge burden on health systems in schistosome endemic countries, these countries will continue to hemorrhage resources, finances, and lives to this disease. The effect is to keep the health systems weak, so as to compromise the ability for timely surveillance, detection, and containment of the next COVID-19, Ebola, or Zika. Health system strengthening means that we need to take away silos and standardizing integration and integrating surveillance, detection, and containment of responses across health programs. That is what we're working towards, and this would make health programs more cost-effective and efficient. So taken together, including the treatment of FGS in sexual and reproductive health in Africa will accelerate the health gains for women and children of women of reproductive age on the continent. You will hear of the stark realities of FGS in Africa from my colleagues later in this panel. We hope that the discussion will progress our efforts and your efforts to integrate sexual and reproductive health interventions and put an end to this neglected tropical diseases. Thank you.
Thank you very much, Prof, for that excellent opening remarks. I think it really sets the tone for the follow-up discussions that we are going to have. May I also invite you to join the panel as you will continue as one of our panelists. I think what you have done is to really give us an understanding why we are talking about FGS in an HIV conference. I think a lot of people struggle with making that connection. So I really thank you very much. Let me just go to our first panelist, Dr. Pamela Mbabazi, who is a physician with more than 20 years experience working for the UN and supporting public health programs for infectious diseases in developing countries. Dr. Pamela, please. We have known about FGS, HIV and cervical cancer connection for a long time. Why the agency now to address these three conditions, including sexual reproductive health, together in an integrated way?
Thank you, Lois. Good morning, everyone. Indeed, Francesca has listed a lot of very important background information, and my contribution will be to highlight why the urgency, despite this disease has been known for a very long time. I'm very grateful for this opportunity to be part of this panel, especially during this year's conference that is aptly titled The Race to 2030, Evidence, Scale Up, Accelerate. Each of these disease programs, of course, has gathered a lot of evidence over several years. There are efforts and strategic documents that have been put forward to support an approach that will push through accelerating to meet 2030 roadmap goals. For schistosomiasis, which is one of the neglected tropical diseases, it is targeted for elimination as a public health problem by 2030. This is presented in the present World Health Organization roadmap to 2030 for neglected tropical diseases. It's also important to note that a disease like schistosomiasis, wherever it exists, indicates that there are inequities for health which persist. And the roadmap for NTDs is aligned to the Sustainable Development Goals with a specific mention of NTDs as a tracer for equity towards meeting, especially the SDG Goal 3. So let's consider what has been done for these three diseases, FGS, cervical cancer, and HIV. Of these three diseases, we know very well that cervical cancer causes very high mortality. In the year 2018, for example, it's reported that more than 300,000 women died from cervical cancer alone. And each country presently is aiming to meet the 90, 70, 90 targets by 2030 that are listed in the Global Strategy for Cervical Cancer Elimination. So 2030 is really a very important goal and milestone community that is also working to end rate by the year 2030. Nevertheless, HIV incidence among adolescent girls and women, these are aged mainly between the ages of 15 and 24, remain highest in sub-Saharan Africa. On the other hand, female genital stomiasis is not reported as a high mortality disease and therefore doesn't attract as much prioritization. This is very unfortunate. And it's generally what tends to happen in the public health space. If people are not being seen to die, they are sort of allowed to continue to exist despite them having morbidity that compromises their quality of life, undermines their sexual and reproductive health, and results in a lot of other ill effects on their health. But because these women remain largely unseen, and that they do not die in large numbers, they do not attract the kind of attention historically that they have needed to be able to address this issue. Research, despite the disease being known for such a long time, if you compare the trajectory research for FGS to that of HIV and cervical cancer, the acceleration hasn't been to the same magnitude. Yet this disease is known to be extremely common wherever urogenital stomiasis occurs. Presently, it's estimated that, as you may have heard, that at least 56 million women in Africa are affected. And HIV and FGS has this associated risk with a 3 to 4 times higher risk of being susceptible to acquiring HIV infection. Yet the disease is largely not mentioned in medical textbooks. And the important thing also to note is of the adults who require treatment for schistosomiasis, presently treatment coverage is under 15%. Clearly, while there are important public health gains being made for cervical cancer with a 2030 target, with HIV with a 2030 target, even with entities trying to meet a 2030 target, we will not be able to get there without changing the current approach to how these programs are being implemented. It was necessary at a time for these programs to work in a siloed manner in order to meet and gather evidence and meet some specific targets. However, all the current strategic approaches to 2030 cannot be attained without intensifying cross-cutting approaches and implementing health service delivery models that facilitate a patient-centered approach. More in populations, it is usually the same girl, the same woman, and for clinicians, we are looking at the same reproductive anatomy at any given time of a female's life course. The urgency presently comes from the fact that we are at a cusp of a unique opportunity despite the COVID pandemic. For each of these disease programs, there is presently the strongest expression of political commitment as presented in the strategic documents I just mentioned towards meeting the targets by their respective targets by 2030. The decade to 2030 is a short time. Delivery of services for these three diseases in an integrated approach is not only about being cost efficient, it is in fact the only practical approach by which each of these disease programs will be able to attain and sustain the described 2030 goals, and in so doing also further advance the sexual and reproductive health rights agenda that is working very hard to reverse the detrimental effects these diseases have on women. Thank you.
You're on mute. Lois, you are on mute.
Lois, you're on mute.
My apologies. I had put on mute when there were some sounds coming through. I didn't realize I was on mute. Apologies. I was thanking Dr. Pamela for that synopsis, which you have just given us, for us to really see why it is so critical for us to address all three diseases, because they do happen on one woman, and in most cases, as we know. Let me move straight to Krina Govender, who is my next panelist. Krina has worked at UNAIDS Geneva since 2009, and she has supported and led on various initiatives in the areas of gender equality, social and health justice, such as the development of the UNAIDS agenda for accelerated country action for women and girls, which also includes FGS. Kina, the question I would like to ask you is that your work focuses on how gender inequality impacts women and girls' sexual reproductive health and rights. Can you please help us understand how the social, economic, and political environment impact women's ability to prevent and treat FGS, and why integration of FGS in sexual reproductive health and rights can help us reduce the impact? Thank you.
Thank you, Lois. Firstly, good morning, colleagues and friends joining us in my hometown of Durban, as well as in this new virtual world of Zoom links. It's a total honor and pleasure to join this esteemed and powerful panel of activists and experts to discuss yet another neglected sexual and reproductive health issue, female genital schistosomiasis, which disproportionately affects African women and girls. It's not lost on us that this discussion is happening during the most significant global health crisis in living history, a crisis which many of us see as shining a harsh but an honest light on the structural inequalities and inequities that exist both within and between countries. We are also aware that those most affected by these structural inequalities and humanitarian and health crises are those who are already marginalized and left behind. On our continent and globally, it is women and girls who continue to face multiple and intersecting and shifting health, social and gender and economic challenges to their health and well-being, including HIV, the epidemic of gender-based violence, the unmet need for modern contraception, poor or no access to antenatal services, cervical cancer disease, and neglected diseases such as female genital schistosomiasis. Now, coming back to your question, Lois, on the importance of integrating efforts for FGS, HIV, cervical cancer, and gender-based violence within the broader SRHR framework brings to mind a really beautiful quote by Audre Lorde, who said that there's no such thing as a single issue struggle because we do not lead single issue lives. These are the exact words that we should bear in mind as we design and develop and implement integrated and quality sexual and reproductive health policies and programs and services to address the diverse challenges and multiple needs of those women and girls who continue to be left behind. Now, going forward, I want to highlight three key strategies, which has highlighted by Professor Francesca and Pamela before me. Firstly, we need to move from the rhetoric of global health commitments for SRHR and HIV integration to resourced action. Member states in the global health community have enshrined their commitment to SRHR and HIV integration, including for FGS and cervical cancer and the new UNAIDS strategy and the 2021 high-level meeting political declaration for HIV and AIDS. Now, in order for these commitments to translate into actual comprehensive, integrated and people-centered programs and services, we need adequate investments and leadership and accountability from governments and the global health community, including funders. Secondly, a biomedical approach is critical, but alone insufficient. We need more and better coordination and cooperation between sectors, movements, and programs. COVID-19 has shown us the importance of breaking down silos, the disadvantages of vertical standalone programs, and the need for collective action and for integrated healthcare as we move forward towards universal health coverage. Last but not least, the most important strategy for me and for all of us in the SRHR, gender equality and HIV community is the engagement and leadership of civil society and community partners in the design, development, implementation, and tracking of policies, programs, and services. In 2018, when UNAIDS and WHO first began our joint work on female genital schistosomiasis and HIV, we were guided by a key principle and approach. which we learned from 4 decades of AIDS activism and the nascent civil society cervical cancer movement. That is to consult, engage, and be guided by the lived experiences and needs of women living with HIV, and those living and affected by HIV, cervical cancer, and female genital schistosomiasis. Engaging civil society and communities not only supports demand creation, it also helps to improve accessibility and efficiencies, as well as to amplify the call for accountability. So going forward, civil society, particularly networks of women living with HIV and SRH activists, are our greatest allies. In this discussion going forward, our colleagues Patricia Jaconia and Dr. Islamiyat would be able to give us practical guidance from their lived experience and actual work on the ground. Look, I'm very much looking forward to listening to them and hearing from them in the discussion ahead. Thank you. Thank you very much.
Thank you so much, Krina. I want to go back to Professor Francisca and just ask you a very practical question. From your experience and listening to these the other presenters, how and where do we integrate the treatment of FGS in HIV and sexual reproductive health programs?
Great, thank you very much. So for the treatment of FGS, we already have examples of how you can integrate other programs in the female sexual and reproductive health. And this comes from HPV. The HPV program has been integrated in many countries as part of a package for sexual reproductive health and for managing HIV and AIDS in women. So that is one area where, given that the scientific evidence of the link between FGS and HIV is more or less similar to what we also have with HPV and cancer, I think this is a very good way we can already integrate the control of FGS in existing and successful programs. The other areas where we've been working together with WHO and the UN has been integrating it as a package for deworming women and girls, and really as a form of securing their reproductive health and child welfare. And this is integrating it in antenatal programs and programs that are designed for reproductive health. So I'm going to stop there because I think this is an obvious no-brainer as to where really we have already successful programs for women's reproductive and sexual health, and tagging on FGS control would make efficient, sensible, and cost-effective sense going forward. But I will listen to what other colleagues on the ground have been experiencing in this respect. Thank you very much.
Thank you, Prof. And I think this is an excellent time for us to ask Patricia Jaconia to now come in and present, because as you rightly say, she has done it and she is doing it. So Patricia works as a senior technical advisor at LVCT Health in Kenya, providing leadership in policy and the partnership team. Patricia, can you you've just finished implementing a project on integrating FGS information and services into an HIV program. What struck you the most about integrating the topic of FGS into LVCT's DREAMS project? And what are some of the opportunities for integration going forward? Thank you.
Thank you very much for this opportunity. So I will just share some key things that we picked when we did a study trying to integrate FGS into HIV services within the DREAMS project, which is PEPFAR funded. So the work just began, first of all, with the DREAMS girls realizing how they had very little information about FGS. And so we did capacity building for the mentors and for the community health volunteers to be able to discuss matters of FGS as they provide information to the adolescent girls and young women in the DREAMS project. And also when they go to the community to be able to discuss FGS at household level, and also be able to encourage the women to partake of the mass drug administration that was happening at community level. And so what stood out for us was the fact that people knew very little about FGS. They had heard about bilharzia, but then people did not really resonate with it. They had no local name for it. And they spoke probably about some of the symptoms and gave it a local name using the symptoms. So creating awareness is extremely important to be able to also create demand for the services that are being integrated. At the facility level, the providers were actually able to say that they heard of FGS when they were in training, but beyond training, they did not know how to do the diagnosis. So a lot of training went on to support them to be able to do correct diagnosis and also to link the clients to the services so that they can get the treatment. And in terms of integration, we successfully managed to integrate FGS in cervical cancer screening, where the providers were taken through how to identify the lesions and be able to link the clients to services. And from this work, we have been able to put all the evidence together and share with the sub-national level, because in Kenya, health has been devolved. So we have the county level that does a lot of the programming. So we have managed to work with the Ministry of Health and also with the Ministry of Education to see how FGS can also be part of the information provided in school, and currently doing a mapping of the other stakeholders like the Ministry of Environment that needs to come on board. But overall, we have seen the communities now become very positive about FGS and FGS services. Their myths and misconceptions have been addressed, and people are now more sensitive about using the toilets when they want to relieve themselves, because they understand how that contributes to the spread of FGS. So thank you very much. And in terms of opportunities at a national level, we are scaling up HIV and sexual reproductive health integration in public health facilities. So this is one of the areas where we want to push for a policy to ensure that FGS is integrated, and also to address the funding shortages, because FGS has totally been relying on donor funding. So thank you very much.
Thank you, Patricia, for what sounds like a really potent, exciting program that has really made all the theory we're talking about become a reality. And I think Krina in a presentation talked about moving from rhetoric to action. And what we see in your program is that effort. I hope we'll get some more time to talk about how these learnings can be expanded beyond your own country. Last but not least, let me invite Dr. Soneye Islamit Yetunde, who is a public health physician working in the field of community medicine and primary care. And I understand she's also an FGS scholar. We are very excited to have you with us today. So as an FGS scholar, how has this training impacted on your work? And what is needed to ensure FGS is being diagnosed and treated by clinicians and recognized by policymakers? Thank you. Dr. Soneye.
It is possible that Dr. Soneye is having some connection issues. So maybe in the meantime, as we try to get her on the panel, maybe we can take some questions from the floor. Thank you.
So while we are waiting, I see there's a question that I'm supposed to ask any of the panelists who is happy to answer. The question is, how would integration of FGS and HIV practically look like on the ground? Any of the panelists, please feel free to step in.
All right, this is Pamela. Thank you once again for that question. Francesca had actually mentioned some very already examples that have existed in how FGS has been integrated in some programs. For a clinician, assuming, as we see, FGS is occurring in populations that generally have very low resources. So it's about identifying opportunities as to when you can, not only there's the prevention aspect, which is key, and then the treatment aspect. The best thing is really to prevent. We would not like anyone to develop FGS. That's the key thing. So practically on the ground right now, health workers and communities that are aware that know that there is schistosomiasis in the area should be accessing the praziquantel that has been made available through a generous donation that most governments apply to WHO for and obtain to be able to treat children such that they do not develop FGS in the first place. Praziquantel also should be made available in the health system of countries to treat adults when they are exposed to infested waters and also acquire this infection. That being said, there are barriers to accessing healthcare generally, and policymakers need to work through to ensure that these barriers are minimized or eliminated so that individuals can get praziquantel as and when they need it. This we have described in the document Normal Neglect, where we have outlined opportunities over the life course of a female as to when they can receive praziquantel treatments. There are pediatric formulations that are being made. So a child who goes for vaccinations, who goes for the well child clinic should be treated. A school-age child during their school health days should be treated. The mother during antenatal care and following up during her should be treated. So praziquantel should be given over the life course of a woman. That's the key message, making sure that praziquantel is available and that at any point of interaction, these women and girls are given praziquantel to prevent infection and also treat early morbidity when it occurs. That's the most practical way to do it. Thank you.
Thank you. I have a follow-up question, which is if we are talking about someone who is working in HIV in the community, what kinds of symptoms or how can they screen to know that potentially this woman has FGS?
So maybe if I could come in based on our experience. So part of the training that we had for the providers and also for the community health volunteers is to be able to ask questions like, is anyone, like in a household, is anyone exhibiting blood in urine? And if it's somebody who's come for a HIV service, they would be asked a similar question. If they have seen any blood in urine, do they have any irritation of the skin, or no, any irritation of the vagina or anything like that. So there are standard questions that we can also make available that people can be asked as they're being screened for other STIs.
Thank you. Thank you very much. So I think the question I have, again, maybe Prof. Francisca or anyone can respond to this question. How can we make policymakers or donors understand the seriousness of integrating FGS so that they can provide the resources for that to happen?
Thank you for that question. So I think any policymaker is going to be convinced by evidence. And we already have a lot of evidence on the burden of FGS in schistosome endemic areas. We also have a lot of evidence on the impact of praziquantel treatment on reversing the early signs of FGS. We also have an impact or evidence on what happens when you bring in schistosome control programs in terms of incidence and prevalence of HIV. And this is some of the early work that was done by Patricia Ndlovu and Uren Ketland in Zimbabwe. So I think we had a question which is asking about the scientific evidence linking FGS to HIV. Obviously, we're working with human beings and not mice. So we are not in a position where we can go and do an experiment where we infect people, or we infect the host, treat them and see what happens. But we can have a look at what happens when you do have women at the early stages of FGS. You treat them for schistosomiasis, and you look at the incidence of HIV in those women. And studies doing that, there's a lot of studies showing that. So what you're looking at is the evidence for the outcome of treatment. We have mechanistic studies. Yes, we do have, I think if we go back to the work on the FGS Atlas produced by WHO, we can see clear links there. But for me, as an intervention person, I'm particularly interested in what happens when you do treat schistosomiasis and FGS to the incidence and prevalence of HIV in that community, in the women. Thank you.
Thank you so much for that response. I have one final question for each one of the panelists. We have a diverse group of speakers in our session today. What action do you plan to take around FGS in the next 12 months? And what is it that the people who are watching, how can they get involved? Are there any existing plans or actions that you know that are happening in the coming 12 months?
If I can go first, because I have a vested interest, I'm actually holding a document here. I don't know if you can see it on there. So this is a document it's a policy brief. We've been working together with WHO and UNICEF. It's called Deworming Adolescent Girls and Women of Reproductive Age. So this is a policy brief we've been working on for the past couple of months. It will be launched at the end of this month, and we will have a big global launch just before the World NTD Day in January. And the purpose of this really is to provide policymakers as well as program managers and implementers with guidelines of how we can integrate the treatment of women and girls for parasitic infections, the helminth infections, but particularly for schisto because of FGS. And this really is gathering momentum and is providing the information, the evidence, and the tools for how we can do this effectively and quickly. So please do look out for the policy brief. Do ensure that the policymakers and stakeholders in your countries, in your communities, and actually the affected women have access to this policy brief and understand what we're trying to achieve. Thank you.
Thank you. We will make sure that policy brief is on our website. So those who want to access it, if you go to the Frontline website within the next few days, we will engage with Prof to make sure that it is also on our website. Any other panelists?
Perhaps if I could go after Francesca. As Francesca shared, there are these types of documents that exist. And in my opening remarks, I mentioned 3 important strategic documents for FGS, for HIV, and for neglected tropical diseases. All of them with a common target 2030. These also, I would suggest, be made available through your website. Importantly, because they are a very strong expression of political will from the global community and have been signed off by member states. Now, what are we doing as a follow-up to that? It's one thing to say the thing, to write these things as Karina mentioned, but it should not just be rhetoric. We are working to ensure that we provide attendant resources at a global level as best as possible. For schistosomiasis, we encourage countries to take advantage of the global donation that exists of praziquantel, but also to procure praziquantel to ensure that there is treatment of adults in their populations at risk. Not least of all, we should harness synergies. We will be working to see how best harness synergies between these different programs in various ways. And in so doing, as we harness these synergies, we will have to work across sectors, across disciplines, and promote country ownership. That is key in terms of what we'll be doing as follow-up. And in all this, country ownership actually is a big word, but in reality, to make a difference, what we need is community ownership. Like Patricia mentioned, when communities understand the cycle of transmission of this disease, when they understand that their use of toilets, it actually results in impacts how this disease is experienced. When the myths are busted about the disease not just being one that results into all these issues that result in stigma, ostracization of women, when the communities understand these programs, they will own the program. And that's what we should actually ultimately look out for community ownership. That's the only way we'll be able to sustain and maintain the gains we can make against these 3 diseases, especially for FGS. Thank you.
Thank you. I think what you have already also done is to start talking about how we can bring FGS into the mainstream discussions of HIV and sexual reproductive health. Any panelists who wants to say something to that?
Sorry, I just wanted to add a few more things that we intend to work on in the next 12 months. We have identified champions at policymakers level. So we want to build their capacity, work with them so that they're able to lobby for budget allocation at the county level. And then once we manage to do that, we also want to bring together different sectors that have a role to play in ensuring that communities are empowered, that services are available, that people are aware of FGS and Schisto. So those are like our key highlights, and working together with the policymakers to develop a policy, because it is through a policy that they are also able to lobby for budget allocation. Thank you.
Thank you, Patricia.
Lois, I'm afraid I might have the last word here, but I just want to back up what the other panelists have said going forward. And the main message I want people to take home is engage, empower, and mobilize civil society and communities as equal partners going forward. And demand resources to actually transform that rhetoric and the commitments into resourced action going forward. Thank you.
Thank you. You've done a great job, Krina, in wrapping this session for us. If there's anything that we take away, is that we must continue to engage, we must empower, we must mobilize communities, we must mobilize our political leaders to take serious the FGS and to understand that it has direct implications on HIV and cervical cancer and sexual reproductive health issues. I want to thank all of you, particularly my excellent panel, for waking up so early in the morning and sounding so bright and confident. I think a lot of people like me have really enjoyed this session, particularly the learnings. We've learned a lot, we continue to learn. And I hope this is the beginning or the continuation of us making efforts to bring FGS into the mainstream of our conversations that we are having on HIV, cervical cancer, and sexual reproductive health. I would like to thank the team behind the scenes for making this session successful. Thank you very much. Bye.